Thank you to both chairs. I normally find myself as part of a polarised debate when I'm talking about this field. I'm either arguing that too much marathon running is bad for you, or sometimes defending the fact that too much marathon running has no impact on someone with a normal heart. So I'm in a slightly different territory today because I'm going to be talking to you about, I'm going to try to give you a balanced talk if I can, but I guess it would be right to say before I even start that too much of anything is bad for you. I've heard André Leguer say that too much water is bad for you. Too many vitamins are bad for you, and he's certainly not wrong. But let's just start off by talking a little bit about the benefits of exercise. The governments in the Western world, one of their main goals is to curb this oncoming epidemic of obesity. So we know that certainly exercise prevents obesity. It is associated with a good blood pressure profile. It increases insulin sensitivity, and those people that exercise regularly are less likely to be diabetic. It also improves lipid profile, and there is evidence that people who exercise regularly have a lower risk of premature coronary artery disease than those individuals that are sedentary. Indeed, people who exercise regularly live about 7 years longer than those that don't do any exercise at all. And these are very old data in the 50s published in The Lancet, where they compared coronary artery disease rates in sedentary busmen and postal workers versus active busmen and postal workers. The green bars are the active guys, the blue bars are the inactive guys. Oh, sorry, the blue bars are the active guys, the green bars are the inactive side. And you'll see that coronary artery disease rates in the active people were 50% less than those in inactive individuals. This was an old study. But this is a much more recent study, and it's looking at lots of people, nearly 45,000 professional males, with a follow-up of nearly 500,000 person years. And this shows that people who run just over 1 hour a week have a 48% less chance of coronary heart disease than those people who don't do any exercise at all. So we know that people who exercise are less likely to get coronary artery disease, but apart from the cardiovascular benefits, it's also recognized that exercise may lower the prevalence of certain malignancies such as breast cancer, prostate cancer, and carcinoma of the colon. It reduces the risk of depression. It's regarded as revitalizing therapy. It improves confidence and may reduce the onset of dementia. So if it was someone like me, I would want to have a life a bit like this, where I'm jogging around with my partner in my 70s and smiling rather than be loaded with all sorts of pills and Prozac when I'm a bit older. And I think most of you would agree that that's what you want to be like in your 7th and 8th decades. But what is regarded as beneficial exercise? These are the current physical activity guidelines. In adults, the Chief Medical Officer's report suggests that 30 minutes of moderate intensity, approximately 5 days a week, or 20 minutes of vigorous activity 3 days a week, which accounts to about 42 METs, is roughly what's required to remain well with respect to the cardiovascular system. In children, this is higher, 60 minutes in children of moderate intensity. For those of you that don't deal in METs, what does a MET mean? Well, 5 METs equals a VO2 of 17.5. That equates to doing a 25-minute mile. That's what's regarded as beneficial. Let's put it up to 8 for those of you that feel a little bit more active. That equates to 28 mils per kilogram per minute, and that equates to a 15-minute mile. Most of you will think, gosh, do I really have to get out of bed just to do a 15-minute mile? Those of you that do a lot of running, but that's the sort of exercise that's supposed to be beneficial. What about higher intensities of exercise? This is a paper by Kokkinos, who looked at people who did less than 5 METs exercise and those that did more than 10 METs. And they found a 13% reduction per every MET of increase in exercise capacity. And this slide suggests that those people that are a little bit more vigorous with their exercise are likely to do better than those people who do very little exercise. But even this does not equate to something like this. Here we see top marathon runners who finished the marathon and look like they've not done anything. But remember that the way the things are going now, there are about 500,000 people that run a marathon in Europe each year, and about another 500,000 that run a marathon in the States. So 1 million marathons are run at least once in the UK and the US. The question really is that people who train for marathons don't just do 10-minute exercises. They exercise for several minutes, so maybe a 300 or 600 minute week. That's 10 to 20 times greater than the recommended requirements. And the question really is the dose benefit. Just like any other drug, we know that too much of any medication can prove poisonous. The question is, does too much exercise cause harms? Certainly to the musculoskeletal system, we know that if you exercise a lot, you will eventually get arthritis of your knees, you get back pain, heat injuries, and all sorts of other things. But what about cardiovascular damage? Is there a point at which exercise actually becomes detrimental? Well, there's a very interesting study which hasn't been published yet, which is a 15-year follow-up of 15,000 people, and they compared event rates and prognosis in individuals who exercised a lot, and they found that people who ran a lot had a 19% lower all-cause mortality than those people that didn't. And this is the interesting point. To benefit most, you had to run between 1 to 20 miles per week at a speed of 6 to 7 miles per hour, around 2 or 3 times a week. That's where there was benefit. Once you exceeded 20 miles per hour, once you exceeded 20 miles a week, or a speed... When I mean 20 miles a week, I mean doing 20 miles in a week. Once you exceeded 20 miles in a week, or you ran at a speed of over 8 miles an hour, then the benefits of exercise disappeared. So the only thing that really we have to cling on to at the moment is these visible events that we see, i.e. sudden cardiac death during marathon. That's the only time people put their hands up and say, oh my God, marathon running is bad for you because people die doing the marathon. So let's just look at these event rates. I'm only going to use the London Marathon experience because this data is collected systematically. We can account for every fatality in detail. So in the 32 years experience, we've had over 800,000 runs. We've had 18 fatal and non-fatal cardiac arrests, which have resulted in 12 deaths. And that equates to a cardiac arrest rate of 1 in 45,000. So that is not horrific. And if we look at the causes of deaths, 56% are due to coronary artery disease, about 13% are due to hypertrophic cardiomyopathy, and 12% are due to non-cardiac causes. So based on this, you would say that death rates during marathon running are low. When they do occur, they occur in predisposed individuals, i.e. those people that already have a cardiac problem, where exercise merely acts as a trigger of sudden death, but not a direct cause. But the question, I think, that's the burning question is marathon running actually deleterious to the normal heart or capable of predisposing to an abnormal heart? That's the burning question. Well, we've got some people in the audience, people like Rob Shea, who spent a lot of their careers doing this work, looking at this concept of exercise-induced cardiac injury or exercise-induced cardiac fatigue. Several studies have looked at this, where they've looked at either biomarkers of cardiac damage after exercise or assessed cardiac function immediately off exercise. And for the sake of time, I'm only going to show up some of the results, but there are lots of studies here looking at LV function. Many studies have shown impaired myocardial relaxation immediately post-marathon running, and some have shown impaired systolic left ventricular function, and more recently, impaired right ventricular systolic function. And there are various mechanisms for this. People feel that the heart may not be working brilliantly because there may be free radical production causing myocyte necrosis. There may be impaired calcium sarcomeric kinetics causing impaired relaxation. There may be downregulation to beta adrenal receptors causing a reduced inotropic state. Or the increased free fatty acid concentrations reduce oxidative capacity. So there are many theoretical reasons why this may happen. But the important thing is when this does happen, it reverses after 2 or 3 days. If you tested a marathon runner 4 or 5 days after the marathon, cardiac function is completely normal. This is a slide looking at biomarkers of damage, specifically troponins. Many studies have shown that people who run marathons, triathlons, or Ironman have elevated troponin levels. And again, this study, a meta-analysis by Rob Shave, looking at over 1,200 runners in total, showed that about 50% of people who participate in endurance events have a raised cardiac troponin. But what was interesting about this, that this didn't just happen after the marathon. Rob Shave then went on to show in laboratory conditions, they put a cannula into someone and got them to run a marathon on the treadmill. And they found that the troponin started appearing in the blood after just 30 minutes of exercise. So the question mark is, what does that mean? And when they look at the kinetics of troponin, there's an early rise in cardiac troponin, followed by a rapid decline, so that after about 48 hours, you don't detect any cardiac troponin in someone's blood. This is quite different from a myocardial infarction, where troponin rises after about 4 hours, it peaks at around 12 hours, and stays elevated for several days due to degeneration of the sarcomere. So based on this, there is a feeling that this troponin leak may be coming from the cytosolic pool and may not be of any significance at all. People have failed to demonstrate any link between biological markers of cardiac damage and dysfunction on cardiac MRI. And Rory O'Hanlon's work has failed to show any evidence of myocardial inflammation or myocardial edema immediately after marathon running using MRI, which is obviously much more specific than the echocardiogram. So how do we interpret these raised troponins? Well, it's difficult at this moment. These are small studies. They are cross-sectional. There's very short follow-up. It's a transient phenomenon that we see. There's no real scientific explanation for the mechanisms of exercise-induced cardiac damage or exercise-induced cardiac fatigue. There is very little correlation between troponin leak and cardiac dysfunction in most studies, although there have been some more recent studies that have shown some link. And there is no real demonstrable evidence of cardiac inflammation immediately after marathon running. So people may say, well, let sleeping dogs lie, forget about these troponins, marathon running is absolutely fine. This is a consequence that we need to accept, and we need to study this in a bit more detail. But some of you might be going out tonight, and some of you may be downing a few pints, or maybe half a bottle of wine, or a bit more. And when I measure your ALT and AST tomorrow, it'll be elevated. And when I do an ultrasound of your liver, it'll be completely normal. And your AST and your ALT will come down after about a day. And I will say that was only because you had a bit of a drink. Just don't drink too much. We know that people who continue doing this eventually get cirrhosis of the liver, which is not picked up in the acute phase. So, ladies and gentlemen, could these troponin leaks over many, many years result in a form of cardiac cirrhosis that predisposes to arrhythmogenesis and impaired cardiac function? So we get a bit controversial here, of course, especially because I see a lot of marathon runners in the audience. So troponin release equates to possible myocardial fibrosis plus cardiac dysfunction and arrhythmia. So what's the evidence for this? Well, the evidence really is not great. It's based on case reports, and it's based on very small MRI studies. I'd like to just talk very briefly about case reports. Let's give you one of our cases in the London Marathon. We had a 44-year-old male, several marathon runs, had a sudden death. His post-mortem showed nothing more than extensive myocardial scarring in the presence of normal coronary arteries. Let's take the case of Sy Ma, the world record holder, well, was the world record holder for running the most marathons. He ran over 500 marathons and eventually died from a malignancy rather than a cardiac fault, and donated his body to science. And when they cut his heart up, because everyone was interested in his heart, they found focal fibrosis of his papillary muscles, but nothing more than that. If we look at myocardial fibrosis on MRI, again, very few studies. This is a study of 12 lifelong veteran athletes. Remember, this is not just the ordinary guy that runs marathons. These had run over 100 marathons. None of them had acquired risk factors for coronary artery disease. They were compared with 12 active and healthy matched controls. These people were quite old, were aged 50 to 69. 50% of these, 6 people, had late gadolinium enhancement. And if we looked at these in more detail, one had a pattern consistent with myocarditis, one had a pattern consistent with possible coronary artery disease and infarct, but 4 had non-specific patchy myocardial fibrosis for which there was no obvious explanation. There was another study by Brookman and Molenkamp of 102 healthy individuals who'd completed at least 5 marathons in the past 3 years and did not have any risk factors for coronary artery disease. 12% of these had late gadolinium enhancement. Of these, 7 had non-patchy fibrosis, 5 had a pattern consistent with coronary artery disease, and of those 5 with the pattern of coronary artery disease, 3 end up having a coronary event, suggesting that in some of these people, the fibrosis may be due to coronary artery disease rather than to anything else. Our own experience of pathology post-mortem, this is a pathologist looking under the microscope, we find fibrosis in 6% of athletes. Having said that, none of these guys that we found fibrosis in were marathon runners, 1. They were all, except 1, younger than 30. So if you're thinking that the cumulative impact of frequent marathon runs causes fibrosis, these were young, and these didn't run marathons, so they don't fit with the pattern that we're talking about. But I feel, and this is controversial, that these troponin leaks may be dangerous. And what's the evidence for that? Well, the indirect evidence is arrhythmias. I think nobody can disagree in this room that there is compelling evidence that people who run a lot have a much higher prevalence of atrial fibrillation. And atrial fibrillation, ladies and gentlemen, is not an arrhythmia that we should be ignoring. In the vast majority, it increases mortality 2-fold. There are plenty of papers showing that people who run a lot develop atrial fibrillation. The prevalence of atrial fibrillation in the normal 45-year-old is about 0.5%. In contrast, the prevalence of atrial fibrillation in those people who engage in regular endurance sport can be as high as 13%. Okay? Most studies show that people have a 5-fold greater risk of atrial fibrillation if they run a lot compared to if they don't. So what's the trigger? The trigger, of course, is pulmonary vein ectopy, but what's the substrate? The substrate with sport is atrial stretch, myocyte hypertrophy, atrial dilatation, and inflammatory response, and even atrial fibrosis. These are all mechanisms by which athletes who run a lot may develop a higher prevalence of atrial fibrillation. What about ventricular arrhythmia? This is a trace in a basketball player who's having lots of ventricular arrhythmias, and this is some of his 24-hour tracing. And this is not a very nice trace to have. You can't look at an athlete and say, oh my God, you've got a bit of broad complex tachycardia. You must be fine because you're a runner. But what did the Italians find? They've done a lot of this work. They looked at a very large proportion of athletes, nearly 16,000. They found that 2.2% of these athletes had 3 ventricular ectopics on a resting ECG, and 0.4% had more than 200 VEs on a Holter, and some had bursts of non-sustained ventricular tachycardia. You'd expect these 0.4% to have cardiac problems, such as cardiomyopathy. But when they went to investigate them, they found that nearly 75% did not have an obvious cause for their arrhythmia. The question is, were these microscars causing these arrhythmias that we haven't been able to identify because our MRIs aren't good enough to show them at the moment? They detrained these people, this small group of 70-odd, and they found that their cardiac arrhythmias went down in about 70%. But 30% didn't show any reduction in their cardiac arrhythmia. And when they investigated those 30%, they found that the vast majority of those people didn't have an obvious cardiac cause for their arrhythmia. So even when they detrained, a lot of these athletes continued to have malignant arrhythmias that could be regarded as malignant in some cases. What about sinus node disease? A lot of cardiologists in the audience will tell you that if they look after athletes, the veteran athletes often have very scary pauses on their 24-hour tape. Here's a study looking at 62 former professional cyclists. These are people that had stopped cycling for a long time versus golfers, and you can hardly classify golf as an intensive form of exercise. But still, if you look at the prevalence of sinus node disease, it was 10% in the cyclists versus only 2% in the golfers, Atrial flutter, 6% in the professional cyclists versus 0% in the golfers. Pacemaker implant rate, 3% in the cyclists versus 0% in the golfers. Non-sustained ventricular tachycardia, 15% in the cyclists versus only 3% golfers. Makes you think, doesn't it? What about adverse LV remodeling? Rory, Michael, Abbas told you that athletes get big hearts. They get thickened ventricular walls. There's no doubt about that. You have to have that to be a good athlete. And this is a bar chart showing the distribution of LV cavity in a group of young, healthy individuals, showing that 45% of athletes have a big LV cavity and about 14% of a cavity that may exceed upper limits of normal. But what happens when we detrain these guys? This is a study of 44 Italian top-notch rowers who were detrained for 53 months. Whereas the wall thickness went down, 22% of these individuals had a persistently enlarged left ventricle. The argument is, could exercise have caused an increase in the collagen matrix and adverse LV remodeling that will never normalize again? And could this cause problems later on in life? Here's another study. Just look at the LVED. Peak means at peak exercise. DR means detraining. These are guys that were detrained. You'll see there's hardly any change in their ventricular size once they stop competing. If it's all physiological, it should all go back to normal. So the question is, why not? What about left ventricular hypertrophy? Who dies with LVH on the pitch? It's usually the black athletes. They get the most hypertrophy. And when we do PMs on these guys, they've got heavy myocardial masses of 500 grams or more with no myocyte disarray, which is the hallmark of hypertrophic cardiomyopathy. The question mark is, in these people, Afro-Caribbeans particularly, is this an HCM variant, or, dare I say it, is it physiological LVH turned pathological? Another question mark. Then I come to right ventricular damage, and I am aware that Hein Heidbucher will be speaking after me, and André Lagerche. This is really the Leuven syndrome, I think, and a very good one as well. But I don't want to dwell on this because they may talk a lot about it. We keep talking about the left ventricle. No one really talks much about the right ventricle until the last 10 years. But remember, the right ventricle is a very thin structure. It has to pump against a relatively low pressure. The pulmonary vascular resistance is relatively low. And there is not much capacity for it to get any lower with exercise. Now, with exercise, of course, our cardiac output goes up from 5 liters per minute to 25 liters per minute. Our systemic vascular resistance drops because of arteriolar vasodilatation. We don't quite get that drop in pulmonary vascular resistance in the lungs. So the pulmonary artery pressure may go up to around 80 millimeters of mercury with exercise, really impounding this very thin ventricle, which is taking more of a flak than the left ventricle. And André Lagerche looked at this. He looked at 40 healthy endurance athletes. He looked at their cardiac function before exercise, immediately afterwards, and 7 days afterwards. And they did troponin studies and did all sorts of very interesting investigations. But the 2 points to take away was that the right ventricle at the end of exercise was bigger than the left. The right ventricle didn't contract as well as the left. And troponin levels seemed to correlate with the magnitude of right ventricular systolic dysfunction. I should say that this did all reverse after about a week. We look at his mentor, Hein Heidbucher, who presented data many years ago. He observed, sitting in Leuven in an EP lab, that he was dealing with these endurance athletes who were presented to him in a tertiary center with symptoms. 65% had syncope, 2% had aborted sudden cardiac death, 50% had palpitation, and they all had complex ventricular arrhythmias. And when they investigated them, they found that almost 60% fulfilled the criterion for ARVC. Obviously, when you're sitting in a tertiary referral center, could this be referral bias? But the question really is, was he dealing with real genetic ARVC, or was he dealing with an exercise-induced syndrome? These guys didn't do very well. 9 people ended up dying during the follow-up period, and 9 got an ICD, so very high event rates. And his colleague, or maybe his fellow, Hector, looked at the right ventricle in more detail. And he found that these guys with symptoms had baggier right ventricles than those guys without, And the possible explanations were, does the RV unmask mild ARVC? Does exercise actually cause ARVC? Or are these troponin leaks causing fibrosis in the right ventricle, which promote arrhythmias? Andre Lagos then went on to do gene testing in these athletes, and he found that compared to the normal population of ARVC patients, where we find a gene in 40%, he could only find a gene for desmosomal mutations, the causal genes, in 12%. And the question is, can exercise cause this problem, cause detachment of desmosomes, causing myocyte detachment, which eventually results in ARVC, something like this. And this is their hypothesis. Acute injury, in most people, nothing happens. In some predisposed individuals, eventually, they will go on to develop a form of ARVC. And we had to write the editorial for it. And of course, when you write an editorial, you've got to be a bit tongue-in-cheek sometimes and a bit aggressive. And my questions really, and they will, I'm sure, answer, is that the people that they got in Belgium were very severe cases. These are guys that are having VT. Are these your normal athlete? One. Two, they had very abnormal ECGs and a very high burden of VT. So are we seeing the sickest people? The event rate was much higher than you'd expect in normal ARVC. And the patients who died were much younger than those that didn't. So if we're saying that exercise cumulatively causes RV damage, then the question is, why did the young die more so than the old? I'm not saying I disagree with them, but I'm just being a bit difficult because it's an open debate. Animal studies have been very good. They did some animal studies in Wistar rats where they conditioned these guys for 16 weeks. They electrocuted them again and again so that they kept running for 60 minutes, 5 days a week. Not normal features, but they echoed them, they MRI'd them, they did EP studies of them, and they looked at fibrogenic markers. And they found that these rats, with exercise, developed lots of fibrosis in their atria and their right ventricles, and they had a much higher inducibility for VT afterwards, okay? And all the fibrogenic markers were elevated. This would fulfill the Leuven syndrome, that this happens, this is what goes on. But what happened when they kept a few rats? They detrained them for about 18 weeks. And what happened when they detrained them is all this fibrosis disappeared, okay? So the question mark is, was that fibrosis a compensatory mechanism to allow the right ventricle to cope with the wall stretch? And does this all go away in human beings? Secondly, as opposed to the Leuven syndrome, the RV in these rats was not dilated as one would expect. Of course, this is a rat and not a human being, and you may not be able to make direct correlations. And I want to just finish with accelerated arteriosclerosis because I'm not as convinced about this data. There is some data to suggest that if you exercise a lot, you may predispose yourself to coronary arteriosclerosis. This is a study on 108 males aged 50 to 72. And if you looked at their calcium scores, the marathon runners had lower calcium scores than non-marathon runners. But if you compared calcium scores with matched Framingham-based controls, then the marathon runners had a greater increase in calcium scores than those people that didn't run marathons. And there was also a twofold increase in late gadolinium enhancement in people with marathon running. In fact, if you looked at their coronary calcium scores, those people with a coronary calcium score of over 100, the marathon runners, 3 of those ended up having a serious coronary event in the next few months. But be cautious, ladies and gentlemen, because 56% of these runners were current or former smokers, and this may not represent people like you who've never smoked in your life, who've been running marathons for many, many years. So, ladies and gentlemen, marathon running, it certainly predisposes to AF, there's no doubt about it. It causes sinuatrial disease. Does it accelerate arteriosclerosis? We know it causes myocyte, we know it causes a troponin rise. But does this result in myocardial scarring, which predisposes to ventricular arrhythmias? Does it cause dilated cardiomyopathy or ARVC? There is some evidence that it does. And will that in return cause ventricular arrhythmias? Does it cause pathological LVH? So, is marathon running, for some people, bad for your health? Possibly, is the answer. But let's look at sudden death rates in marathon running. 2 per 100,000. People who run marathons usually lead a healthy lifestyle. they're less likely to smoke, they're less likely to booze heavily, they're less likely to be fat. And let's look at the deaths in the UK from people who smoke, booze, and don't exercise. They're much, much higher than they are with marathon running. So marathon running promotes a healthy lifestyle overall. Our graveyards are full of people who died of coronary artery disease. There are very few graveyards that hold marathon runners, people dying just because they were running marathons. So ladies and gentlemen, there are millions of people who run marathons. This is the base of the pyramid. There are a number, about 50%, who get raised biomarkers of cardiac damage. But I think the data that you're seeing in athletes that are dying or developing cardiomyopathy are basically the very, very small number that present to major tertiary centres, and of course we need to learn. I think there is certainly a place for this. I do think that too much marathon running is bad for you. That's my personal feeling. But before we conclude that, it's early days. I think we need prospective studies, longitudinal studies, before we conclude that marathon running is cardiotoxic. Thank you very much for your attention.